you were going in with like an earache, and they were like, oh, by the way, pee in the cup, and as a result, they were picking up more disease. So realistically, probably wasn't the epicenter of, but unfortunately, got that reputation at some point as a result. They call it magic. We have the PA students for America. So I'm always like, yeah, how's school going? Just sit far away. So, what'd you think?
I said I went to Marist. I got my bachelor's from Marist.
Yeah.
I never, no. I just went home like this.
We call that an asymptomatic infection. So, I'm just kidding. Never had chlamydia.
No, I'm not, because I never slept with anyone from Marist. You're welcome.
Strong words.
Just to be clear.
She's immune. So anyway, pretty easily spread. Basically close contact, sexual contact. I don't know about this sharing of contaminated clothing or towels. I remember reading this last year and being like, I don't know if that's true. It could be, but I'm gonna. And this also seems a little fishy to me. Depends on the patient population, right? 25% of Marist students, 25% of Americans, 25% of people that have sex with prostitutes. It's hard to say, but that 25%, I don't think men. There's a 1 in 4 chance of somebody having chlamydia, but who knows? Something we could look up at. You can't get chlamydia from a toilet seat, so you probably, that's why I would think, get it from clothing that's that's what they taught me. So, anyway, chlamydia when symptomatic, which in men, commonly, men and women, patients can be asymptomatic and have it, but usually gives you a urethritis-like picture, urethritis, epididymitis, cervical pain, discharge, inflammation. The discharge can be kind of any color. If they develop PID at that point, are symptomatic. Prostatitis, proctitis, proctocolitis. You can get chlamydial infections of the oropharynx as well from oral sex. Conjunctivitis is like the leading cause of preventable blindness in the world. That's why when you're born, they give you a drop of sulfacetamide in your eye and to prophylactically treat if the mom has chlamydia. That's like sort of standard with all these wounds, unless something's changed since I did a long time ago. So infant pneumonia. Once again, effective hand washing and washing otherwise, I guess. So chlamydia is also easily treated. The recommendations these days, we use doxycycline for it. They recently changed the recommendations. It used to be just a shorter course. Now it's 100 milligrams twice a day for 5 days. We used to give azithromycin, 1 dose, a gram, like Z-Pak, basically 4 pills of a Z-Pak at once. But they found that resistance, like that's the problem with all these infections that are very common, is resistance eventually evolves in almost every therapy we do over time. So now the recommendation is doxycycline twice a day for 5 days. PO azithromycin, we still give it if we're highly suspicious the patients aren't going to complete the regimen antibiotic therapy. So you get somebody who's, IV drug abuser with, has no chance of following up, and you don't think there's a chance they're going to fill the prescription, then you can PO azithro because the risk profile of treating successfully is lower with 1 dose. General warts. So what's the virus that causes general warts? HPV. So human papillomavirus. Get little papilloma. These are warts. So general warts are caused by HPV. There's like 100 different strains of HPV. The problem with, general warts are a problem. Don't get me wrong. Like you don't want general warts, but what you really don't want is the high-risk strains of HPV because HPV also causes cancer, right? So cervical cancer used to be the 8th most common cancer women. Now that we do screening, I think it's a little bit down as far as commonness of cancer. But HPV has been implicated in, besides cervical cancers, which used to be the primary thing that everybody was concerned about. There's been a huge incidence of oropharyngeal cancers and even lung cancers that are HPV related. And so the good news about HPV related cancer is it's more amenable to therapy and treatment than smoking related oral cancers, but still is cancer. It's not a good thing. So HPV in general, HPV infections are super common. Like I forget the statistics, but like there's an enormous number of people that get HPV in the United States, like a majority of people at one point or another, and most people just clear the infection. It's when the infection doesn't clear or is present for a long period of time that it causes an inflammatory process that eventually results in cancer. So it's a small percentage of patients. Like so, if you look at the overall population of patients that have HPV, you're talking about 1 or 2% developing cancer with HPV high risk strains. But that 1 or 2%, if everybody in America has it, is quite a lot of number of people. So it's still a high risk problem in the United States and actually worldwide. Worse outside of the United States. The strains that cause cancer are just a few of the 100 different subtypes. So I think it's 15 and 16, HPV 16, I don't know, 51. There's 4 like super common ones, and we have a vaccine for HPV, which is somewhat controversial in the United States because people are like, I don't want my kids having sex, but you can't prevent your kids from having sex, which is why it's probably better that they get the vaccine and don't get cancer. They also might not get warts. But really, the whole point of the HPV vaccine is to prevent cancer later on in life. And in that sense, it's probably quite a beneficial treatment for kids. But you have to get it. It's usually given like kind of around the 12-year-old, before they've had a chance to get HPV infections from sexual encounter. So you want to get the vaccine early. These days, they've now expanded the age range for vaccinations for HPV. I think up to 45. Because they found that there is benefit in patients up to their age and preventing cancer. That being said, we're talking about STDs, and genital warts are a manifestation of it. Trichomoniasis is another protozoan infection that is commonly sexually transmitted. Men frequently are asymptomatic, kind of similar to chlamydia in that regard. When it is symptomatic, presents with urinary frequency, dysuria. Sometimes they can have a purulent discharge, itchiness. In women, they get a vaginitis-like picture when they're symptomatic, like foul-smelling vaginal discharge. Can be concurrent with gonorrhea and chlamydia. And this is treated with, anybody know? Flagyl, the antibiotic, metronidazole as the treatment. You can get, for men, they use a one-time dose of 2 grams, and for women, you do a week-long course, 2 or 3 times a day. All right, moving along. Scabies. Oh my God, it's 10 to 10. Mm-hmm. So scabies, moving along. Sarcoptes scabi, skin infection that we see commonly in patients that are at risk of poor hygiene. Direct skin-to-skin contact can be sexually transmitted, so to speak. Bedding, if the person, if you're sharing a bed with somebody who has scabies, and very recently can give you disease. The mites that cause, the scabies mites burrow into the skin in 2.5 minutes, so it doesn't take too long. And then basically, manifests with skin lesions. This isn't the greatest picture, but I don't know if you can see the little lesions that patients have very commonly along the web spaces in the fingers. Very itchy. Scabies and bed bugs oftentimes get confused, but the lesions do look somewhat different. Oftentimes these patients have linear lesions like one next to the other in a line. Can be kind of anywhere really. The classic is the bigger web spaces. Um, Oftentimes these patients are all excoriated because they eat so much. So obviously you want to minimize any exposure. So if it has scabies, try to keep your distance. Cover them up with a sheet. The treatment basically is kind of head to toe application of and then you wash it off in the morning. Sometimes people need a second treatment. Lice, pediculus capitis, pediculus pubis is pubic hair lice. Corporus, pediculus humanus corporus, body lice. There, Thyris pubis, crab lice. Either way, the lice you can see. I mean, you can see the little nits. Once again, these are oftentimes the way we see them present in homeless people, people that are, poor hygiene, and then kids, one kid gets lice and then everybody in the bunk gets lice. That's like a classic story. Crabs are sexually transmitted. A lot of lice. You can comb out the nits when you have head lice. Bed bugs. So bed bugs, small, brown, like reddish insects. They're tick size, and they bite and feed off of human skin. Drink your blood. They bite at night during the sleep, and then the patients have lesions all over them. Oftentimes we'll use some topical corticosteroids to treat the bites, but really it's a self-limited kind of thing. You just have to get them off you and off all the clothing or the bed that they came from. I thought there was a lice bedbug slide. Zika virus, there's an outbreak of this a couple years ago in Central South America, Brazil, I think. I think the big concern was, once again, it's sort of torchlight in the sense that pregnant mothers can have babies with microcephaly when you get it. For everybody else, it's mostly sort of a viral picture. Most patients are asymptomatic. When they do get symptoms, it's sort of that similar picture: fever, rash, joint pain, conjunctivitis, etc. And recent travel, and it's like a Zika endemic area. Lyme. So we have 5 minutes, 6 minutes. So we'll cover Lyme and then cover everything quick. Borrelia burgdorferi is the bacteria that causes Lyme. It's a spirochete like syphilis. Lyme is another one that can present with varying disease presentation depending on the course and timing of the infection. Tick-borne, it's like syphilis, occurs in phases. I mean, it's a spirochete disease, so that makes sense. Sort of same type of infection in that sense. Initial signs and symptoms that people present with Lyme, the classic one is the Lyme rash, right? So erythema migrans. The problem with erythema migrans is here you have the classic bullseye rash, right? But the erythema migrans can look a lot different. It can look like a big circle. It can look like a swollen area. It can get mistaken for cellulitis. It can be quite tricky. The only good news is that doxycycline also works against cellulitis. And so if you have a lesion that you're thinking, is this Lyme? Is this just cellulitis? Usually it doesn't hurt. Whereas cellulitis, redness, swelling, redness, erythema, rubor, calor, it's warm, hot, and red, and tender, and hurts. Whereas the Lyme rash usually isn't painful, but it can be. And so that's why it's kind of tricky. But like I said, if you treat the cellulitis with doxy, then you're kind of covering both at the same time. So the rash can be tricky, but usually, the classic rash is this bullseye presentation. The problem with Lyme is that there is no test like that shows up positive early on. That's a big, people are always like, I need to get tested for Lyme. You don't test a person for Lyme if they have symptoms of Lyme until they've had the disease for at least, or they've had the infection for at least about a month, because it takes about a month for antibodies to develop. It can take up to 6 weeks. And So if you acutely test somebody when they present with a bullseye rash, you're going to miss, and don't just treat them, then you miss the diagnosis because the test frequently will come back negative, and you're like, oh, you'll be falsely misled that it's not Lyme. And so primary presentation of Lyme disease, you just treat as opposed to testing. So the sort of secondary signs, so secondary Lyme, I guess you'd call it, is when the Lyme has progressed past just the dermal manifestations. And oftentimes people will just have fever and body aches in summer and no rash. So it can be tricky. And so very commonly, Lyme will spread will progress from a primary infection to sort of the second stage. And that point, people can present with varying symptoms. The most common signs and symptoms of secondary Lyme that we see are like a swollen joint. So it doesn't present like a septic arthritis, like if somebody has an acute bacterial, like invasive infection of a joint, it's exquisitely tender to move. So they have a swollen joint and they're like, like when you do that, like really pain. Whereas Lyme joint infection, it tends to be more like they have a swollen joint and it hurts, but it's not like you can range their joint and they won't have they'll have some discomfort, but nothing like severe. So you can get swollen joint, very commonly Bell's palsy in this area. Can be caused by Lyme disease, and so oftentimes if we have a new onset Bell's palsy, we'll prophylax them with treatment. The thing about you can get Lyme meningitis, which is sort of a low-grade meningitis. They have fever, body aches, some photophobia, and some degree of neck stiffness, but it's not like severe. Like it's more like a viral meningitis. Is kind of what it looks like. Usually, in order to have joint infections, Bell's palsy, or CNS infection like meningitis, the disease has been present long enough that the test is usually positive, but not always, which is why it's tricky. And so oftentimes we'll treat these patients anyway. We will test them when they have those symptoms because you're looking for, there's good odds that it will be positive at that point, but sometimes it's not, and you treat them anyway and then have them test a month later just to make sure one way or the other. So that's sort of the secondary stage of Lyme. And then the tertiary stage is when you get cardiac abnormalities from it or severe CNS abnormalities. So patients can get an encephalitis-like picture. They can have mental status changes, confusion, psychiatric manifestations. Cardiac-wise, the classic is like an AV block. So these patients have myocarditis. And at that point, the disease is pretty advanced. It's still treatable, but sometimes permanent side effects can happen. And that's why there's this whole theory of like alternative medicine theory of using like prolonged antibiotic therapy, like going on ceftriaxone injections for a year. The infectious disease side of America says that's not necessary. There's sort of this other group of doctors that think it is. There's a lot of politics involved. I don't know if you ever read about any of this stuff. It's controversial. It's not controversial to most providers, but there's a small subset that believe otherwise. So Lyme disease, late stage, chronic arthritis is difficult to go away, encephalopathy, cognitive deficits, depression, sleep disorders, CNS effects from untreated Lyme for a long period of time. Sometimes those symptoms don't go away. In general, you have to be aware of it. The key, we call Lyme like sort of summer flu. So patients presenting with flu-like symptoms in the middle of summer, body aches, fever, you worry about Lyme. And now we worry about the other two tick-borne infections very commonly. Babesiosis, there's been an increased rise of babesiosis, and anaplasmosis, the other, or used to be called Ehrlichia, or ehrlichiosis. These are the trifecta of tick-borne diseases that we see in the summer from various bacteria. West Nile. So West Nile is one of those, the reality is most patients that have West Nile have no idea that they had West Nile. They felt sick for a little while and got better, and no one knew better or worse that they had West Nile because you only test for it when patients have severe illness that we're not sure what is causing it. And so, somebody presents with encephalitis and they working them up and everything's coming back negative, then the samples get sent to the CDC, or actually New York State to Wadsworth, and then they test for it and render a verdict. And that's usually when patients with West Nile end up getting diagnosed after no one can figure out what's causing it. 20% are symptomatic. That means that 80% aren't. So you never knew you had the sickness. Fever, headache, body rash, swollen lymph nodes, and then untreated or unimproved and patients at risk of decompensation, the very old, the very young, usually the very old, end up with encephalitis, like picture, altered mental status. Rocky Mountain spotted fever is another tick bite illness that we don't really see. It's more like Appalachia, where it's common. Fever, headache, abdominal pain, vomiting, muscle aches, and a rash. It's treated with doxycycline as well. So if you mistakenly think they have Lyme, so food poisoning characteristics: diarrhea, vomiting. Call it food poisoning. You really need diarrhea. The classic mistake in medicine is we misdiagnose somebody. They have vomiting and abdominal pain, but no diarrhea, and it ends up being an intra-abdominal thing like appendicitis or diverticulitis. And the most commonly misdiagnosis for appendicitis is gastroenteritis. So we label it gastroenteritis erroneously, and it ends up being an appendicitis, which is why if somebody doesn't have diarrhea, they just have vomiting, don't call it gastroenteritis unless you have diarrhea as a component. That's the easiest way to avoid misdiagnosing somebody. Certainly, you can have just vomiting from foodborne illness. There's lots of different things that can give you food poisoning. E. coli 157H7 is one of them from undercooked meat. Salmonella, Campylobacter, the other bacterial causes of gastroenteritis. CNS infections, we're almost done. I'm done in less than 3 minutes. So CNS infections, encephalitis, basically meningitis is inflammation of the meninges, encephalitis is infection of the brain. It's oftentimes viral. West Nile can give you an encephalitis-like picture. It can be caused by viruses, it can be caused by bacteria, etc. It's just sort of a term we use when the brain itself is infected. There's lots of other, so sinusitis very commonly is just viral. It goes away and gets better on its own. Every once in a while, bacterial sinusitis can give you a high fever, a lot of purulent discharge, and usually just not getting better after a period of 7 to 10 days. Initially, the treatment is really just a steroid, and in cases with bacterial sinusitis is suspected, then we use antibiotics. But we try to avoid antibiotics for this because it gets used all the time and it's not really fixing much. Hantavirus, we talked about earlier, this disease of the Southwest. So nosocomial infections, which are the last couple of slides, infections that occur in hospitalized patients. Some are from drug-resistant infections, VRE, vancomycin-resistant enterococcus, MRSA. MRSA is a community version and a hospital version as far as different strains that cause infections. RSV, we talked about. MRSA, community MRSA usually presents with abscesses and cellulitis, skin infections, and this MRSA is everywhere in the community now. So used to just be sort of people that were of unclean nature, jail patients, homeless patients. Now everybody, wrestlers get it, etc. Super common. MRSA in the hospital in immunosuppressed patients is more serious. These patients can get MRSA pneumonias, etc. VRE, vancomycin resistant, VRSA, sorry, vancomycin resistant Staph aureus, certainly not very common, but increasingly present. Immunosuppressed patients are at highest risk. VRSA, will give you skin infections, pneumonia, meningitis. You can get lots of different. It can affect any part of the body, but usually just affects people whose immune systems aren't great. VRE is another nosocomial common hospital spread infection among immunocompromised patients. Can give UTI and sepsis. VRE, prolonged catheter use, etc. C. diff, you guys know C. diff. This is one of those that you have to wash your hands because the spores are not killed by the alcohol wipes that we use. So if you have a patient with C. diff, You always want to use soap and water. Another infection, basically you go on a course of antibiotics for a prolonged period, you kill off all your gut flora, and then C. diff happens to be present in small quantities and now has an exposure area that they can infect because the normal bacteria are killed, and that's how we get C. diff. That's treated with different antibiotics. Gives you commonly foul-smelling, frequent, intractable diarrhea and abdominal pain. Cause a colitis-like picture in some patients. So to prevent disease transmission, don't work if you're sick, wash your hands, wash the rest of your body if you're doing something else. And there we go. Any questions? Sorry, I ran over. I thought I was going to be good.
You did fine.
Thank you, Dr.